NPTE Studycast.
All right, welcome to NPTE Studycast, here with Bridget Ripa. Bridget, heterotopic ossification. It's so much fun to say and so difficult to spell.
And so difficult to work with.
It is. So briefly, what is it?
So HO is the formation of bone inside soft tissue structures where it's not supposed to be. The development of HO is extra-articular, so it occurs outside the joint capsule.
Well, I remember I had no idea this thing actually existed before I came to PT school, and I was like, wait a second, bone can just randomly form?
Yeah, I don't think I knew it existed until I was, maybe I got that information at some point in my education, and then until I saw a patient with it. And it's rough, for sure.
So what's involved with anatomy or the injury? How does it happen, and what does it look like when it happens?
The exact pathophysiology behind HO is actually unknown. They don't know exactly how it happens, but it usually comes from a period of immobilization, some sort of traumatic injury to that bone or to that area of the body.
What does it look like in the body? How does somebody figure out that they're actually dealing with this?
I think the first time I saw HO, I 100% thought it was a DVT. So it presents a lot like that swelling, redness, kind of warm to the touch wherever it is. A lot of times it presents like an infection to that specific area. Your thrombophlebitis, your osteomyelitis, cellulitis, sepsis or septic arthritis. And then you can also see it present kind of as a fracture, just a trauma, or just a really, really bad bruise or hematoma. But those are kind of the big things that you would see.
Special tests.
What are the tests? How do we prove it? I'm guessing X-ray.
Yes, you are correct.
Thank you.
Yeah, so X-ray is the gold standard for identifying it. You can also do a bone scan.
Treatment examples.
What does a PT do about it?
Unfortunately, when it gets to a point where you know that it's HO, as the PT, we're not doing a ton other than just maintaining the range of motion of that joint, or that area that we already have, as well as maintaining muscle strength so that you don't have to worry about muscle atrophy and joint mobility down the line. But the big thing in these patients is prophylaxis. So beforehand, before you even see HO, you're going to be wanting to maintain that range of motion. So really looking at positioning, splinting or bracing if necessary, things like that early on so that you can hopefully avoid HO developing.
Look at that. Movement is good for you. Who knew?
Who knew?
Here's your example question.
And then how are we going to see it creep up on the NPTE? What's this going to look like?
You're probably not going to get a specific question about HO. I mean, don't hold me to that. You might have HO integrated into a question that you're going to want to consider that. Kind of a sample question, if they were specifically asking you about HO, they might say, during an initial evaluation of a patient, status post motor vehicle accident with a complete lesion at C7, the therapist notes swelling, redness, and warmth at the posterior knee joint. Which of the following conditions would most likely be present? And that's where, dependent on your answers, if HO was an answer, you probably want to go with HO. But a perfect example of how HO has a lot of differential diagnosis.
Right, because it could look like a DVT as well. That's where my head might go
Definitely.
as well.
Yep, absolutely.
Perfect. Heterotopic ossification. Good luck with it on the NPTE.
Exactly.
NPTE Studycast. Brewed by the PT Pintcast.